Good evening, everybody, and welcome to the October 15th edition of the Southern California Center for Oral and Facial Surgery Study Club. As you know, we're not meeting in person at Braemar Country Club. We have no idea when we're going to be able to go back, but we're doing the best we can with this live stream broadcast
and welcome to the October 15th edition of the Southern California Center for Oral and Facial Surgery Study Club.
There we go. And we are really happy to see you all here. I hope you're doing well. We have a really interesting lecture tonight given by one of my oldest friends, Dr. Catherine Hayes, who actually we went to dental school together. And then she went on and got her both master's and doctorate degrees at Harvard after doing a GPR at Brigham and Women's Hospital in Boston. She is a diplomat of the American Board of Public Health Dentistry and past president of that organization. She's currently a clinical professor of health policy and health services research at the Henry M. Goldman School of Dental Medicine at Boston University, and a lecturer at Harvard School of Dental Medicine and director of the dental services in the Division of Commonwealth Medicine at the University of Massachusetts. You must be busy, Kathy.
Busy, just like you, Jay.
Yeah. All right. So you're going to speak tonight about practicing evidence-based dentistry in clinical practice. So really interested in hearing what you have to say, so we're going to let you take it away.
Okay, thank you. So I'm going to see if I can share my screen. I just had to switch computers at the last minute because my other one decided to restart. So actually what I might do, Jay, is forward you those slides because they don't seem to be coming up here.
Oh.
And I don't know why.
Okay.
But basically, I'm not sure why they're not coming up. Strange.
And you're in Chrome and you see share screen?
I'm in Chrome, I see share screen, and I hit application window. I have the file open, and let's see. Let me just try.
Worked
again.
when we tested it last night.
Okay, here we go. Here we go. Looks like it's coming up now. Finally.
Hooray! Okay, here we go. All right,
Yay.
Kathy.
Okay.
take it away.
Patience is a virtue. So, we hear a lot about evidence-based dentistry, and, really, what is that? It really is bringing, the research into a clinical practice. And how do we do that? And how do we evaluate the research? Because there's so much out there every day that's being published. Thousands of articles every day. And what I like to say to people, and when I teach my students, it's like, I want to for people to be educated consumers of the literature. So really being able to evaluate, what do I want to bring into my practice? What is important in terms of the patients that I see, and what is good evidence, valid evidence, and how do I evaluate it? So this is a hierarchy of evidence that we think about in research. So when we're talking about clinical research, we have to keep in mind that we're never going to get to the level of control that we have in a laboratory setting. If you're studying, let's say if you're doing animal research, for example, you can control everything. You control the environment, the temperature, everything that's being eaten, the administration of medications, the exact dosage and timing. You can even control the genetic strain of the animals. You put that into the human realm and you lose that control, right? So you send people home and you give them instructions. You don't know, whether even if they're in the treatment arm, let's say, of a study, you don't know if they're 100% compliant, right? And you don't know what are the other factors in their environment that might be impacting the outcome of the study. So we evaluate, Go ahead.
I was going to say, was looking for a good place to interrupt. I forgot to mention that anyone who has questions on your live stream broadcast, there's a space to the right of the screen where you can type in questions under chat, and that way we can ask Dr. Hayes the questions at the end of her lecture. Okay, sorry to interrupt.
Sure, no problem at all. And Jay, as I'm talking, if something's not clear, please feel free to jump in. I'd be happy to have a dialogue.
Okay,
So
sounds good.
this is what we call kind of a hierarchy of evidence, and I'm really focusing on clinical research here because that's, as clinicians, it's important. There's a spectrum of research, right, from the molecular level to the population level and everything in between. When we're talking about evidence-based dentistry, we can look at basic science for mechanisms of action, et cetera, but we're really looking at what's happening in humans and in the real world as to what we're going to bring in our practice. So the highest level of evidence is a systematic review, which is bringing together the evidence from randomized controlled clinical trials. And we can also look at other studies as well. But remember, when we're doing human research, we always have a subset of the population. You can't study everyone that has hypertension, right? So we always have a subset of the population. Well, how do we know if that particular subset really represents the true population? So that's why we repeat studies, and we do them, several different studies and several different populations. Did you say something, Jay? So a systematic review is bringing together all the evidence from randomized controlled clinical trials. So a single randomized controlled clinical trial is the next level of evidence. The reason for that is by randomizing people in a study, that means that everyone who's enrolled in the study has an equal likelihood of getting into treatment A or treatment B, or treatment versus placebo. And that's important because what happens is that on average, those study groups will be balanced. And they'll be balanced in terms of percent male, female, average age, percent smokers, et cetera. And that becomes important. And just store that for a moment. When we get to talk about confounding, we can talk about why that's important. So that is what we call an analytical study. A cohort study is where we study just groups of people. For example, you might study women who are on postmenopausal estrogen replacement therapy, or people that work in a certain industry. So they're identified on the basis of an exposure, and then you follow them over time. You're not assigning the exposure, they're already in an exposed or non-exposed group. A case control study would be if, let's say we were looking at oral cancer and smoking. We would identify cases of oral cancer, and we would identify controls of people who don't have oral cancer. And then we would study them and compare differences. Now, case report and case series is something we see quite a bit of in the dental literature. And they're important, but they can't really give us a high level of evidence. So it's important to describe interesting cases or cases that you've used a new technique on, but we have to bring them further in the research process before we can really evaluate the effectiveness. An expert opinion, there's a funny story about back in, I want to say like the late 50s, early 60s, the dean of Harvard Medical School, as the students were graduating, he's congratulating them at graduation, and he says, we feel pretty confident that 50% of what we taught you is based on the evidence. We just don't know which 50%. And so much is really based on the opinion of the instructors, right?
Right, exactly.
So, yeah. So one of the things I look at, clinicians are so busy. So you pick up a journal article, you pick up a journal, let's say after the end of a busy day, you're going to scan the titles. So a title should really be informative and should tell the reader exactly what they're looking at. The more detail, the better. When you look at the introduction of the paper, so I want to give you just like some tools as to how to read each paper. So if this is an area that you're probably pretty familiar with the literature. Did they do an adequate literature review? Did they clearly state what it is they're studying? And are they clear in what it is that they're looking to evaluate at the end? So for example, just saying we are evaluating the impact of antibiotic use on periodontal disease. That's way too general. Which antibiotic, for how long, what dosage, and how are you defining periodontal disease? Are you looking at attachment level, bone loss? So the clearer, the better. And this last one, is the study insignificant? We often say it has to pass the so what test. So what if you study this? What impact is it going to have on the public or on my practice? The methods, I think that we often skip over, or just lightly read the methods. It's the most important part of the paper. Absolutely the most important part of the paper, because this is where we get to discern whether or not this paper is scientifically valid. So I'm going to talk about types of studies and when do we use a specific type of study. But the methods are really important. It's also the part of the paper where you can evaluate, does this matter to my patients? Are these study subjects similar to people that I would see in my practice? And Jay, I'll give these slides to you so you can share them.
Okay, great.
With the group.
Great.
Okay.
Perfect.
The results should be, you're welcome. The results section, you should be able to look at a table or a graph and not have to go back to the text. It should stand on its own, and you should be able to tell exactly what the results are and how to interpret them very quickly. And statistical analysis, I'll just say, I'll talk about this in a moment, but the statistical analysis, the real reason we used statistics is to help us to discern whether the results that we have observed in this one single study occurred just by chance alone, or are they likely to be real? So I'm going to talk about a p-value in a moment, but if we think of the normal distribution, we know that about 68% of the population lies within plus or minus 1 standard deviation, and approximately 95% of the population lies within plus or minus 2 standard deviations. We are looking to see this line in the sand that we use in research is 5%. So what we're looking for is, are we 95% certain that these results didn't occur by chance? Because we can't really rule it out completely. So there's many, many different statistical tests, but all of them are helping us to discern whether or not the results occurred by chance. We're going to talk about types of bias, because whenever you're studying human populations, there's going to be potential for bias on the part of the researcher and on the part of the study subject. How you collect the data, all of that. So in the discussion, you want to make sure that they have talked about, they go back to what they started out with. So they go back to the literature from the introduction, and they begin to interpret their results in the context of what's been studied previously. And it's really important. Every study, no matter how well designed it is, no matter how large and statistically sound it is, every study has some limitations. So what we want to ask ourselves is, what's the likelihood that there's bias, chance, or confounding? And I'm going to go into each of those. The authors should also give you some alternative explanations for the study's findings. They're not trying to tear their study apart, but they're trying to give you some food for thought. No matter how well that study is done, no matter how well designed it is, it's one study. And one study can't talk about cause and effect. It can talk about likelihood. It can talk about associations, but a single study isn't going to tell us that something is actually causative. And that's really important, especially these days when there's so much out there in the literature about, the virus, et cetera. We need to have replication, and I'll talk about that in a moment as well. The conclusions should really, not overstate or understate the study's findings, and they should go back and directly be related to the hypothesis, the study aim. So it should all be kind of nice, neatly tied together. So I want to just talk briefly about the different types of studies. I talked about the hierarchy of evidence. So let me break that down for a moment. So descriptive studies, as the name implies, are studies that describe a population. It could be a snapshot in time, like a cross-sectional study. We look at, NHANES, for example, the National Health and Nutrition Examination surveys that come out every few years that are really a snapshot of the population. What's the prevalence of periodontal disease? What's the prevalence of caries? It can be a snapshot of the population at a specific point in time or a period of time. It could be, for example, people entering college. It could be the United States population in 2019, whatever it might be, but it's a point in time. A correlational study is a type of descriptive study where we're looking at population statistics. So, for example, you might say, let's look at the death rates in a state, and let's look at the cigarette sales, and you plot them. So you have an x-axis and a y-axis, and you plot these two variables, and you look for a pattern. Now, the big disadvantage of a correlational study is you don't know if the smokers were the ones who died. You don't have any information on the individual. So the point I'm trying to make is, with all of these descriptive studies, they are important, but they're only the first step in a line of investigation. So a case report and case series, they're important, but we're not comparing them to a control group. We haven't randomized the population. So we need to take it a step further. And I often refer to descriptive studies as hypothesis generating studies, not hypothesis testing. So analytical studies are the second major type of epidemiologic studies. So the difference between an analytical and a descriptive study is, now with an analytical study, we actually have a comparison group. So now we can begin to test hypotheses. So cohort and case control studies are a type of analytical study that we refer to as observational. The investigator or the researcher is not assigning an exposure. They are merely observing individuals who have a natural exposure, or an exposure such as cigarette smoking or a particular type of medication, etc. An intervention study, now these are when these are like the vaccine studies. So you enroll people, you can send people to participate in the study. People will not know if they should be blinded as to which study group they're going to be in. Will they be in the treatment group, or will they be in the placebo group? They should be blinded. The investigator who's going to do the evaluation should also be blinded. And when that happens, we have what we call a double-blind study. The other benefit of intervention studies, as I mentioned a moment ago, is that everyone who enrolls in the study has an equal likelihood of getting into either treatment, and there could be multiple treatments. The reason that's important is that it limits the bias, right? So if we're not saying, the sicker people can get in the treatment arm, or the older people, or the smokers, so it's completely random. And that's really, really important. And why is that important? Because when we look, every time we read a paper, we want to ask ourselves 3 questions. Were these results likely due to chance, bias, or confounding? So I'm going to go through all of those. How do we evaluate chance? How do we evaluate bias? And how do we evaluate confounding? So bias is really just, you're looking for a particular relationship. You're looking for a particular, let's say you're looking at periodontal disease as your outcome. How are you going to measure that? If you're just going to look at, let's say, gingival inflammation or gingival bleeding, highly unlikely that you've got a good description of periodontal disease. So you want to have examiners who are trained. You do probing depths. You probably do attachment level. You do radiographs to look at bone loss. So you really want to have a very precise and valid measure. So looking at bias is to help us assess the validity. When something is biased, it's deviating from the truth. And what we're trying to get to in research is the truth. What's the true association? So we want things to be very precise, and we want them to be replicated. So the more detail that you read in the paper, the better, because it's something that you could replicate. Now, bias can occur when you design the study. It can occur when you're obtaining information from the study. It can occur when you're analyzing results. So it's really important, and a lot of this comes from your common sense when you're reading the paper. If let's say they were looking at periodontal disease, and they took patients from a dental school clinic, and they asked people to volunteer. Now, it may be that people who come into a dental school clinic might not be from the same kind of population that you see in your practice. Maybe they're a little sicker, maybe not. Another example is, let's say you're doing a study of oral cancer. And so cancer cases are identified in the hospital, but the controls are people who live around in the community around the hospital. That's going to be a biased analysis, because, people who are in the hospital let's say you're looking at smoking as your exposure. Smokers are more likely to be hospitalized. So you're already going to start with a discrepancy. Does that make sense, Jay?
Yeah. When I was in general surgery residency, there was one attending who had a higher mortality rate than any of the other general surgeons in the hospital. And you think he was not a good surgeon, but the issue was, or the situation was, that he usually got the sickest patients. So they had a much higher likelihood of dying. So it really is his patient population was definitely biased, and it influenced his outcome. So I know exactly what you mean.
Absolutely. Yeah. And so when you're reading a paper, you want to look at that. So when, for example, if the examiner wasn't blinded, it's not that people intentionally want to bias study results, but just by human nature. If you knew someone was in the treatment arm and you're going to evaluate them, it's not even an intentional thing, but you might do a more thorough exam. You might just look at things differently. So we want, whenever possible, to have blinding of the interviewer, the examiner, and blinding of the subject. And we call that observation bias. It doesn't, the names don't matter. It's the thought of it. So bias is one thing we always want to look for. The next thing we want to look for is chance. So as I mentioned, statistical tests, and there's, many types of statistical tests, but they're all designed to evaluate whether the result that we saw occurred by chance alone. So let me give you an example. Let's say if we were looking at the antibiotic, let's say we're looking at systemic tetracycline and probing depth, okay? And let's say we had a antibiotic group and we had a placebo group. And at the end of, let's say, a 2-year trial, we saw that the antibiotic group had a 1.5 millimeter, on average, 1.5 millimeter reduction in pocket depth. And the control group had a 0.5 millimeter. So we have this 1 millimeter difference. So did that occur by chance? Was it just by chance that we found that? So we run a statistical test. In that case, if we have two groups and we're looking at a continuous variable like pocket depth, we would run a t-test. And every test at the end of the day gives you a p-value. So the p-value is just the probability of what you observed, in that case, 1 millimeter difference, or something more extreme. Think of the normal distribution. So let's say if it was, 1.2, 1.5. What is the probability that that result occurred just by chance alone? So when the p-value, and this is an arbitrary cutoff that we use in research, when that p-value is 0.5 or less, what we're saying is there's a 5% or less chance that these results were strictly due to a chance observation. So we're willing to say that 5% of the time we could be wrong because we have that cutoff as 0.05. We can never rule it out. We can never say chance wasn't responsible, but what we can say is the smaller the p-value, the less likely it's due to chance. So here, if a p-value is 0.43, what we're saying is the probability that that 1 millimeter difference occurred by chance is 43%. Well, that's pretty darn high, right?
Yeah.
So we're not going to believe that. So we looked at bias and we looked at chance. And this is just, example of, just explaining 0.5 is the cutoff. If you have, so we say if the p-value is less than 0.05, we say it's statistically significant. And if it's really low, let's say 0.001, we say it's highly significant. But always knowing that chance is always a possible explanation. Does that make sense?
Yeah. Oh, perfectly. Yeah.
Yeah. I want to kind of demystify the p-value. That's the only thing it's designed to do, is to evaluate chance. It doesn't tell us anything about bias. Okay.
Right.
One of the things that we also look at are these confidence intervals. That's why it's, when you have a paper that gives you confidence intervals, it gives you even more information. And this goes back to statistical theorems. There's something called the central limit theorem. And it's just like there's a Pythagorean theorem and all these theorems that we learned in school, right?
Yeah, learned and forgot.
Exactly. I know. Did you ever see that little meme on Facebook? Yet another day I didn't use my high school algebra.
Yep.
This is something that's important, confidence intervals, because remember I said, we're only looking at a subset of the population. Obviously, we can't study everyone. So let's say in that study, we found that we had this 1 millimeter difference in probing depth. We had a p-value of, let's say, 0.03. So we conclude that it's statistically significant. And then what we do is we calculate a confidence interval. So what we say is we're 95% confident. Let's say that the true millimeter difference in pocket depth at the end between these two treatments ran from something like 0.8 to 2.2. So what we're saying is in this study we found a 1 millimeter difference, but we're 95% confident that the true difference is somewhere between 0.8 and 2.2. Now I'm making those numbers up. We actually have a way of calculating this. We calculate it from the normal distribution. Remember I said that about 95% of the population lies within plus or minus 2 standard deviations?
Yeah.
So we use that information from the normal distribution, and we use the data from our study. So we look at the mean, which is 1, and we also look at the sample size, and we look at the standard deviation. That all goes into a formula to give us this confidence interval. And it's pretty remarkable that actually works. And that's based on a statistical theory called the central limit theorem. So when you're looking at, and that's important because Jay, what if I said to you, the difference in the two groups in probing depth was 0.8, but the 95% confidence interval went from like 0.2 to 1.6. A 0.2 millimeter difference is not really clinically meaningful, right?
Yeah. Right.
So when you're reading the literature, you can, use your clinical judgment to evaluate these statistical results and evaluate whether or not that is something that you would consider to be something that you want to bring into your practice, right? Because often you're looking at a new treatment or, a different approach to a situation that you treat regularly.
Yeah.
And so
it seems like most of the time, most of what we see in the literature is a lot of case reports. Obviously, it doesn't have, or a new way to do something. It doesn't necessarily mean that it's any better. It's just a different way, without having the statistics to back up that it's an improvement. And in medicine, it's interesting in medicine. There's like a standard way to do an appendectomy. There's everybody does an appendectomy that way. There's a standard way to remove tonsils. There's a standard way to do heart bypass. Whereas in dentistry, it seems like, there's 100 different ways to do everything. And I think maybe it has to do, who knows exactly why it is that way. But how do you evaluate what's the best technique to use, in your practice?
Exactly.
And it's hard. I think a lot of practitioners, a lot of clinicians go by, well, in my hands, this seems to work better, and that's their study, right?
Exactly. And if you go back to the hierarchy of evidence and think about how we were taught in dental school, what's the lowest rung of that ladder is expert opinion, but just like the dean of the medical school said to his graduates, we're not sure which 50% was based on the evidence.
Exactly.
So much of what we do clinically is based on what works in my hands, right?
Right.
It's so true. It's so true. And so whenever we can have a study, and sometimes we can't do a randomized clinical trial for ethical reasons, for example, if you have significant, or even if there's a significant belief that something is going to be beneficial, then you can't deprive anyone of it. So you can't do the clinical trial, right? And so that's why a lot of times clinical trials can't be done. So this is just a review: chance, bias, and confounding. And I want to talk about confounding. We talked about chance. We talked about bias. So anytime you read a paper, ask yourself, are these results due to chance? Are they due to bias? Are they due to confounding? So a confounder is some third factor. So let's go back to the example of oral cancer and smoking. If we were just evaluating oral cancer and smoking, but we didn't take into account alcohol use, for example. Now, alcohol is an independent risk factor for oral cancer, right?
Right.
And it's also associated with smoking. Now, what we would have to do is look at our data to see, did the smokers have a higher prevalence of alcohol use than non-smokers? So you're adding another factor. So let's say at the end of the day, you did a case control study of smoking and oral cancer. You come out with a factor of 5, and you say, well, smokers are 5 times as likely to develop oral cancer than non-smokers, but you didn't have alcohol information. That study is confounded by alcohol. You don't know but to what extent. Now, if you then had alcohol information in the study, what we would do is adjust that. So we would adjust for that third factor. And now we would say the adjusted rate might be, let's say, 3.2 or something. So it's still a risk factor, but it's attenuated a little bit by their alcohol use. So we have these problems with chance bias and confounding in any study. I don't care how incredibly well done that study is. These are always problems. So with confounding, what we try to do is randomization with a clinical trial, but you can't always do that. You might have a rare disease, which you're going to use a case control study design for. Sometimes we restrict it and we say, okay, we're only going to look at smokers, or we're only going to look at non-smokers. That's also really logistically difficult. And sometimes we match, and you'll see this a lot. I'm sure you've come across this a lot, Jay, in papers that you read where they say they matched on age, for example, or they matched on sex or whatever. And that's to just try to minimize the impact of that confounding factor. That's why we do that.
Yeah, apples to apples.
So, exactly. Yeah. And when I talked about that we have to replicate studies, we are always looking at a subset of the population. We do not know if that subset of the population is representative of the true population. So we have what we call criteria for causality, and we apply this to a body of literature. And all of these criteria for causality are not always possible to be met, but I'm going to give an example in the literature where all of them are met, and it's a great example. It's the relationship between folic acid and neural tube defects. Now, years ago, there was a question, does folic acid prevent neural tube defects? There were many studies. There were clinical trials. There were cohort studies. There were case control studies. And all of them found very strong associations. So the first criteria is the strength of the association. Now, if we say smoking and lung cancer, the risk for lung cancer among smokers is a 10-fold risk. That's a strong association. With folic acid and neural tubes, it went the other way because it was a protective association. But what we saw repeatedly in the literature was that women who had folic acid during the critical window of embryogenesis, when that neural tube was forming, they had a 70% less likelihood of having a child with a neural tube defect. That's a huge association, right? Biologic credibility, it has to make sense. Well, it does make sense that folic acid would be important. It's certainly important during embryogenesis. It's important to RNA and DNA synthesis. We have lots of cell replication during that time. So yes, it makes sense that if folic acid were there in abundance, it would improve, the replication of cells and create the healthy environment. So that's satisfied. Consistency with other investigations. This is why I say replicate, replicate, replicate. One study, even if it's beautifully done, is one study, and we have to have consistency. These studies were remarkably consistent. The strength of association was consistently 60 to 70%. The temporal sequence, this is often one that we can't look at, but in this case, it was beautiful because what they were able to see was that women who had the folic acid vitamins during the time of neural tube closure, which is 28 days. So these are people that were taking multivitamins on a regular basis, and that's usually before people even know they're pregnant. So when they did studies of women who didn't have folic acid during that time, but maybe took it starting at 2 months or 3 months, they did not have that protective effect. So they were able to determine that there was a temporal sequence here. And the dose-response relationship, again, this is one that's not always possible to look at, but in this case, they saw that women who had, let's say 1 milligram versus 0.5 had a stronger protective effect. You can see this with smoking and periodontal disease. Heavy smokers have a higher risk of periodontal disease. So when we talk about dose response, it's not necessarily what we think about in a pharmaceutical trial, but more just in a more of a kind of a gross analysis of that. And then we go back to the levels of evidence. The systematic review, why is that so beneficial? Well, because you're looking at a group of studies where you've evaluated chance, bias, and confounding in each of those studies. And so you have a conglomeration of data. You begin to look at the consistency amongst the studies. Randomized controlled trials, these are very good because by randomizing, you balance the study groups. And what's really important here is that you balance them in terms of known confounders, let's say smoking, alcohol. But the beauty is, we don't always know all confounders. You balance them on all factors. And you can double blind randomized controlled trials. You can't do that with a lot of other studies. So then we go down and we see here, Jay, as you were talking about, the dental literature is replete with case report and case series.
Yeah.
And it's not the highest level of evidence.
Mm-hmm.
So this, I just made a little chart here of different studies so that your viewers can take this, and as they're reading a paper, they can ask themselves questions. Was it the study, the treatment status clearly defined, et cetera. So I'll just give those to you for each of the study designs.
Okay.
And
great.
Yeah, and that's it. And then we can just come back and have a chat about it.
That sounds great. Yeah, it's for those people who are in academia and researchers, they can read an article in a journal and look at it in a completely different way than someone who basically has a purely clinical background. And it's really important to know when you're reading an article, is this something that I should give credence to? Is it, is it just a small sample that really doesn't mean anything? How well was the study done? You could spend a lot of time, you'd spend more time trying to figure out if the article is worth reading than it takes to read it. Mm-hmm. But the information you've given us tonight is really good. So when we read articles, we can look at them a little bit more critically and understand, is this an article that's worth believing and worth our time?
Yeah.
Yeah, great.
Yeah, look at them with a critical eye. Every year, Jay, I do this session at the Harvard Dental School with the various postdoctoral, like the endo students, ortho students, et cetera. Mm-hmm. So first we have a discussion like we just had here, and then I assign them as a group. So all the endo students take a topic that's controversial in your area. Same with all the disciplines. Use these criteria to evaluate the literature and then come back and present it to the group. Yeah. And invariably, they're stunned at some of the widely, accepted treatment practices that they've been taught. If you look at the literature, sometimes they're supported and sometimes they're not.
Yeah.
And so just having a critical eye evaluating the literature is so important.
Yeah, very important. After all, we do have doctoral degrees, so we should be able to evaluate the literature and in an intelligent way. So, thanks for giving us an outline of what we should be looking for and explaining the different parameters that make a study worthwhile. So we really appreciate it.
My pleasure.
Let's see. I guess nobody typed in any questions. If you do have a question for Dr. Hayes, it's the last chance to type it in. Remember, a lot of you, of course, always ask, email me afterwards, how do I get my CE? And so what we do is everyone who's registered will get an email that has Dr. Hayes' CE quiz, and you have to answer 70% correct to pass. And when you pass, you'll get your CE credits. And if you're in California, you'll get a State of California Dental Board of California CE certificate, and if you're outside of California, you'll get an AGD PACE certificate. So on the quiz, we always specify which type of certificate you need. So normally October is our last study club, sometimes November, but with things being so crazy, we're going to try to enjoy the holidays with our small group of our families as much as we can. We're anticipating having a very interesting schedule for next year, some great speakers, some great topics in 2021. as of now, we're not sure if we're going to be meeting in person or if this is going to be kind of the norm for a long time with us doing the live streaming. Nice thing about the live streaming is a lot of people who aren't in our study club throughout the country have been joining us on these lectures, and so a lot more people benefit from our what we're doing. So I guess with that, I guess I'll tell everyone good night. It's let's see, what time is it? It's almost 5:45 in LA, so it's 8:45 where Dr. Hayes is in Boston, Massachusetts. And so thanks for joining us. And always, if you have any questions afterwards, you can certainly email them to me, jay@onlineoralsurgery.com, and I'll get them to Dr. Hayes, and she'll give you as quick an answer as she can. She's, as you can tell from her introduction, she's quite a busy woman. And so until we see you next time, stay safe, stay sane, and enjoy the rest of your evening. Thanks a lot. Bye-bye.